I would like to have a special thought for Dr. Weinberg. I don't know, many of you know him, so he was a colleague and dear friend who died dramatically in April. Special thanks to Alexandra Camille, who passed me many of the slides. To resume about 30 years of treatment, it's quite difficult, and at the end, Clyde asked me to talk a little bit about PrEP too. So I try to do my best, and have you seen, English is not my first language. So the bright side of the therapy, as we said yesterday, at least now there are about 20 million of people having access to HIV drug. We can remember, and people were there in 2000, that there was no people except the rich country who had access to the drugs for many years. And at the same time, there's still 40–50% of people who don't have access to drugs, and there are many disparities around the world, and there are disparities around gender. Men have less access to HIV treatment in many areas in the world. So it's the 30th anniversary after the HIV drug. The first HIV drug was commercial. Is it? So for people who were there at the beginning, we can remember how it was bringing hope that we'll have at least one drug that maybe could fight against AIDS. And after EZT, we had D40, DDI, and it was, we realized that these drugs were not efficient. We did not understand at the time all the concept of resistance. We did not have access to viral load at that moment to get a good follow-up for our patient. So it was in 1996 in Vancouver at the World AIDS International Conference that we discovered the concept of 3 drugs that were necessary to fight correctly against AIDS. Rapidly, we saw very important, I can remember some of my patients. I often said to people, we saw miracle in our office. People were very, very sick and stopped becoming very more healthy. So it was a very, very important, certainly, moment in the history of AIDS. It is certainly the most important moment in the history of AIDS, seeing dramatically the diminution of mortality in countries who have access to these drugs. As I said, it will take many years before access to drugs will be part in other countries. And what we can see now, we can see the disparity, we can see how the life expectancy, it's wonderful how to see how the life expectancy, the impact of HIV treatment in many areas, including many countries in Africa. So in 1999, that was AIDS. So people, I can remember my patients, you know, sometimes today when your patients are complaining because they take 1 pill a day, I said, try to remember, they were taking, because they were taking a lot of medication for infectious prevention for opportunistic infection at that moment, because we treat lately. So it was between more than 20 pills a day. We can remember people were taking AZT every 4 hours. Our patients were waking in the night to take their pills. It was, it's not so far away, so it's interesting to see how things have changed. And rapidly, what we saw, we start to see the side effects of these drugs. So hope was there, many pills, not so bad, but that's when that realized. I still have patients who told me my boyfriend died because of AZT. It's still in the memory of people because AZT was high dose, very toxic, not like today in the Combivir. It was 2,400 milligram a day, so it like a lot of toxic effect. But what happened that was, people at that moment, we did not know too much that it was AZT, but we realized later. And what happened was lipodystrophy, and this was, we were not waiting for that. It was very surprise, starting to see. I can remember my first patient with a buffalo hump. Never heard about that before, what was happening, and it became very more and more important on many patients. At that moment, many patients start to stop their drugs. In our center, if we compare today, about less than 2% of people stop their drug. At that moment, it was near 25% of people who stopped their drug, mostly because of the stigmatization of that. If you were in Montreal, in downtown, people who saw that, they knew that you have AIDS. So it was as worse as the first stigmatization of AIDS at the beginning with Kaposi and other complications. So that was quite a nightmare. And I can remember in our waiting room, this was so frequent that patients that we want to start a treatment, they don't want to start treatment. The first thing they told us is, I don't want to look like that. So it was bring a lot of resistance for patients to start treatment, and people stop treatment. So that's kind of the history of the, so at the beginning there was no treatment, after there was AZT, after there was sequential, D40, DDI, PIs arrived with a lot of hope, and we start again to say hit hard, hit early. I don't know if you remember that. And after we stopped in the early 2000s because of we did not have good drugs enough. And we believe at that moment, at least, not everybody, but many people believe that you don't need a treatment if your CD4 are high. You need a treatment only if your CD4 are low, below 200. That was mostly what people think. In fact, it will take a few years, maybe. There was a lot of debates in the conference to realize, but at the same time, we need good drugs. If we want to treat patients, we need good drugs, not simple, not too many side effects. And to realize that HIV infection is deleterious at very early stage, and as early as we can treat, probably it's better. So major change in drug prescription practice. We have all, I don't know if you can see, but you have 30 years of development of drugs. So we have about 30 drugs that, with 6 classes of medications. Most, I'd say it can do thousands of combinations, but most, there are few combinations at the end which will work. And in 2017 arrived Raltegravir once a day, Truvada, generic, and TAF. So that's very important. The Bictegravir from Gilead with TAF, that will be a very interesting drug because it's like Genvoya, but without, not Genvoya, it's a new integrase inhibitor, no booster, no cobicistat with TAF, so no kidney problem, no bones problem. And dolutegravir, that is a very new protease, not protease, integrase inhibitor that is very prescribed because of very good toxic profile, few side effects, very well tolerated. And there are few people in the world who are resistant to integrase inhibitor, at least now, but it looks that it is very rare. So we work with these drugs, but at the end we work with few combinations. So because we have better drugs, better treatments, there was this concept from United Aid that is very interesting. It's the 1990 that most of know you. In fact, we have all, when I say that to people or media, sometimes they don't understand that concept, you know, because we say we have no vaccine, we have no cure, but at the same time, we have all the tools that can eradicate HIV/AIDS. It's just a question of politic will, because we have to test people. We have to put them rapidly on treatment, and we have to give them a good follow-up to be sure that there's no resistance and they are undetectable. And it's sure that long term it will decrease the number of new cases. But testing is still a problem. In my country, that we consider a rich country, 20% of people who are HIV positive don't know. I think it's similar to United States, I don't know. It's quite high, so how can we stop the epidemic? How can we eradicate the epidemic? Because these people are responsible mostly for 50% of the new infection. So you discussed yesterday, stigmatization is still, in our country, is still an issue. Criminalization is certainly an issue. So to put on treatment, I think is doing well, and viral suppression, I think we're doing well. We'll see, next slide. In fact, Montreal will be, this is our mayor, this is Dr. Zuniga, Minister of Health. Montreal will be the first Canadian city that approved at downtown, at the ville of Montreal, the city of Montreal, that accept unanimously that Montreal will be will sign the 1st of December the United 1990 document, and we'll see after what they will do, because we will give them some opinion about what we should do to eradicate HIV/AIDS. So before choosing a regime for our universal, okay, we know now that it's test and treat, but there's still some specificity. And there are new trendy that we should treat the patient the first day that we see him, that we announce him. It's not always easy to treat the first day, because patients, it's still a bad news to learn that you're HIV. We have new treatment, there's a lot of hope, but it's still a bad news. So when you announce a young person of 22 years old that he or she is HIV and that we want to start treatment, my experience is not so good the first day. I think we can do fast. We have to explain them that we have to do it fast, but most of the time we will like to see the viral load. Are they co-infected? Tuberculosis here in the Caribbean is certainly another issue. Pregnancy, illicit drug use. We have, in our community at least, there's a major problem right now with illicit drug use. The HLE status, if you want to prescribe abacavir, age, comorbidity. Are patients, do they take other medications, previous art exposure? And is it acute infection or advanced HIV disease? It's not always clear. And the regime will have to be, I would say simple is the best answer, at least for young people, but for older people too, because already they take so many drugs that it is very important. Do they have to take food? Is it important, depending of the work they do? Sometimes, one of my patients, I cannot, at that time, he have to get out to take his medication, and he was a teacher. He said, I don't have access to food where I am. So the drug-drug interaction, certainly, the genetic barrier of art, the cost, affordability. In our country, in Montreal, it's different. In Canada, it's different from one province to another. The medications are not completely paid. it's mostly reimbursed, but it's about, I would say, 90%. So we still have patients who stop their treatment because sometimes, some periods, not always, or delay their treatment because that 10% for them is quite high amount, mostly for young person at least. And some of the young people, an issue that we have, they have the insurance from their parents. You know, so they have to announce to their parent that for PEP or PrEP or treatment, so they don't want to tell to their parents. One of our young patient refused a few months ago PEP. He came for PEP, prophylaxis post-exposition. It was very high risk. And when he arrived to the pharmacy, the amount was high, and he said it was the insurance of his parent. He refused. And he became 3 months after HIV positive. So I think it's very sad. So we will certainly try to discuss with the government to try to put that free as possible. In Vancouver, in British Columbia, it's completely free. So it's different. In Toronto, it's another thing. Pregnancy, certainly, if it's a woman, it's different. So if you compare the preferred and alternative first-line options with HIV in different guidelines, you can see that only WHO don't recommend right now integrase inhibitors as first line. All the other guidelines, IAS, DHS, European, French, recommend the integrators as the first line. In the real life, this is, well, so who still recommend Atripla in the first line, but they said that there are alternative combinations, and that dolutegravir could be an alternative, and that efavirenz 400 milligram, because there are studies now a lot with efavirenz 400 milligram. So decreasing the side effects of on the nervous system, but it's not in the first line. This is in Switzerland. 80%, I don't know, in my center, I think it's 60, no, maybe it's 82. 80% of the new in the last year, the new patients who started treatment are on integrase. So, and we try to switch as we can patients on protease inhibitor, and because our population is aging, cardiovascular issue is a very important issue in my center. Most of our patients are doing infarctus like 10 years earlier than the general population, but we're doing better, I would say, than 5-8 years ago, probably because we treat better cholesterol, we treat better high blood pressure, we're more attentive, I would say, to these issues. So, sorry. As I said today, it's uncertain whether the role for dolutegravir is certainly an issue. Or I would say integrase inhibitor, not only maybe dolutegravir, to replace both or with the single regime approach. There's a lot of discussions all around the world. TAF, this is very interesting new drugs. That's a prodrug from Truvada with no side effects on bones and kidneys. So it's certainly, it's approved, but it's not reimbursed, at least in Canada. I don't know in the United States. It's certainly interesting for our patients with comorbidity, aging population, with kidney issues. So make the treatment light and simple. It's certainly the message I would like to send. It's as we can. Different countries. So you can see here you have Atripla, you have Genvoya, you have Triumeq, you will have soon Truvada with TAF with rilpivirine. So depending viral load, depending of the different issues, but certainly we have 6 treatment that is 1 pill a day. So that improve a lot the quality of life of our patient, but at the same time, it's not because we have 1 pill that it's not 3 drugs, so we still have to look the drug-drug interaction and the toxicity of these drugs. And some of these drugs, we don't have so many years of experience, so I hope we will not have these experience that we had with lipodystrophy or that kind of thing, because you know these drugs are studied. That's the problem. The toxicity is decided after 1-2 years of treatment, after the research finish, the trial finish. So the long-term toxicity will really clinicians have to be there to observe and describe if we see something. There's a lot of discussion about dual therapy in many countries. Argentine, Pedrocan, TruTC, Kaletra. New studies show that TruTC, darunavir could be interesting too. And there's study right now with TruTC and dolutegravir. There's small studies that show that it looks interesting, but at the same time, we have to be careful. We have experienced that triple therapy looks to be the best, but it could be interesting. Decreasing the cause, decreasing the toxicity, maybe for some patients, maybe people who are undetectable since a long time, have no mutations, no resistance. It's interesting. Oops. So this is at the International AIDS meeting, what the Alexandra Camille had, is another 90, because good health-related quality of life is very important. So somebody said that penicillin cures, but wine makes people happy. So I don't know who said that. So it's very important. If we want that our patients are adherent, if we want that our patients want to start treatment, don't want to start treatment, it have to be a treatment as simple as possible with less toxicity, with less drug-drug interaction. If we don't have that, we will not succeed. Do we need new drugs? We always need new drugs. What's interesting is that new formulation, smaller pills, very important for some people, that the pill is small. Less frequent dosing. There's some study right now with pills. I think it's Merck who do this study once a week. Long-acting compounds, intramuscular. You know that there's this study right now with cabotegravir. Patients are very interested by the intramuscular. We participate to that study in my center, and it was very easy to recruit patients. I think it's about stigmatization again. I don't think it's about taking the pill. If you could have an injection every 3 months, you know, you don't have to have the pill with you, with your pharmacy, you travel with somebody. People don't want that other people see their pills. So it is very popular. But right now, what we have, the only success, it looks like it will be once a month with cabotegravir, because they stop the once every 2 months. New class of medication, I think somebody will talk about that, monoclonal monoclonal antibodies, maturation inhibitors, capsid inhibitors, and biological remains a challenge, and combination are made possible, but there's still a rich pipeline in the research against HIV. I'm surprised because with all the choice that we have today, it's interesting that the pharma, but less pharma, There are not so many pharma like a few years ago, but there's still a rich pipeline in the access issue. I don't, you know that more than me, so I will. What RV cannot do? Can HIV be cured? There will be a discussion on that. Not sure that RV will be the solution, probably with other things. So let's talk about my practice a little bit, and I finish with PrEP. We have a large cohort in my center. We have about 1,600 patients on PrEP right now. And we have very high-risk population, mostly MSM. Lots of consumer of drugs, cocaine, crystal meth, GHB, very high-risk population. So that's why, and we're lucky. PrEP is reimbursed in Quebec. It's the only province in Canada that PrEP is reimbursed. We did not ask the permission, we prescribe and they accept, and after now they cannot stop. So my clinic is downtown Montreal. We do HIV treatment, but PrEP, PEP, hepatitis, STI research, and our population is composed MSM, drug users, migrants too, from the different areas. So it's a one-stop clinic. We have a pharmacy, we have a lab on the place. It was opened in 1984. We work a lot as a multidisciplinary approach with time. There's family doctors, there are nurses that play a very, very important role, and different specialists that are in the clinic. So our people are getting older. So that's the success. Oops, sorry. So for us, HIV is mostly now a chronic disease. Very, very few of our patients died from AIDS now, since many years. We still have some. We still have people who arrive late with CD4 low, but we start treatment, and we don't have tuberculosis. It's not an issue. So life expectancy is quite high. The problems that we have are mostly related to age, hypertension, infarctus, cancer. If you see that in 10 years ago, about 25% of our patients start treatment at the first year of diagnosis, now it's about between 90 and 100%. Really, our patients start, when they are tested, they start treatment. And they want to start treatment because they know that we have new drugs. They know that it's doing better, they're less toxic, and they know that they cannot transmit HIV. So when you're young, it is very important, not only when you're young, but when you're young, at least it is very important to feel secure with that. So our patients are 90% of our 94 are undetectable below 40 and 98 below 500. Near 60% of our patients are 50 years old and older. So we have the new HIV patients and the oldest population. Whoop. Sorry, I'm in the bad. So that's what is our approach. Mental health issue is still very important. Cancer, kidneys, heart, diabetes. Diabetes, yes, and lots of interaction with drugs. So when I announce a patient, at least I can announce that he's HIV, that his life expectancy is good. If you start with CD4 at 350, you can see that the life expectancy is 60 years plus his age. So it's quite near normal, not completely, depending if you have comorbidity is different, but it's very near normal. Oh, yeah. So we still have to work on lifestyle because you can live all, but maybe it's better not to smoke. So my time is over, but I start later, actually. If you want, the prevention is better than cure rapidly. We have very good result on PrEP. We know the most important problem is the adherence with success from 86 on demand to 99% are the study. So, and there's a lot of discussion of PrEP. The PrEP, you encourage behavior. That's all the debate. You prescribe with the journalists. You know them. I don't know if there are journalists. Media sometimes they don't. It takes time to understand. So, if you prescribe PrEP, you encourage as no. I prescribe PrEP to my high-risk population. When I am in my office, I know that if I don't prescribe PrEP to that guy, he will be HIV in 6 months. Yes, but you encourage bad behavior. So, okay, if we have a vaccine, we don't give the vaccine because we will encourage. The day we have a vaccine against HIV, it will be the same thing. Everybody will go around and will have sex like right now. And the epidemic of STI arrived before PrEP. I can look all the data. The epidemic of STI arrived few years ago, probably related for different things, but maybe because we know that, I don't know, different opinion. So we have a very important safe tool. This is our web page, so we give a lot of information for our patients before they phone. PrEP is taking time, it's a long consultation. So we decide to do Truvada, we decide to do CCAS. Well, if you're looking for people, if you want to interest them, it have to be related to sex often. So we do PrEP clinic. So when a patient calls, he said, I'm calling for PrEP. So it will not like in my appointment of the day between two patients. He passed 1 hour with the nurse and after with us. So, and we collect all the data because we don't want to prescribe that like for 1 year and come back to see me in 1 year. We prescribe every 3 months and patients receive a lot of education at the same time. So we don't see, we saw increase, the research are controversial. We saw increase of STI in some population, others population it's stable or diminished. It's not clear right now. But it's certainly a population that we prescribe are very high risk. So we prescribe about 50, 60 prescriptions per month. PrEP was approved in 2012. We start to prescribe at Lactuel in 2011, mostly to serodiscordant couple. And after the hypergay result for PrEP on demand, we start to do clinic, and it was only approved in Canada in 2016, but we still do it since many years, and it is reimbursed by the insurance of government of Quebec. Our PrEP program involves high risk, a lot of drugs too. 50% have already chlamydia, 60% have already gonorrhea, 27% have already syphilis. We offer on demand or daily. The majority of our patients prefer on daily, but it's changing. You don't put somebody on PrEP for the rest of their life. It's changing. It's, they feel a high risk at this moment. They take PrEP 3 months, 6 months, 1 year, and they stop. They had a new partner in their life, and they stop for 3, 6 months, come back. It's very, very interesting. And some people that start daily will move to on demand, and some people who start on demand will move daily. It's depending very. They don't know sometimes at the beginning. I always prefer to start daily, and after 3 months, we see with them if Some people have few, some people know when they have sex. So on-demand is good. It's mostly oldest men. Younger people don't know when they have sex. It's every day. So with the young people, I'm very prefer daily regime. With the oldest people, they see, they know themselves. The on-demand regime, I don't know if you know, it's 2 to 24 hours before sex and 1 pill a day for 2 days. The on-demand regime, the interesting is less cost, less toxicity, but it's really for people who are very well organized. Who opts for on-demand versus daily? It's mostly younger patients, okay? And Dr. Grant presented in Paris some data. The recommendation, because in Canada the recommendation is daily, it's not on demand, but we do both. United States is daily. France, European is daily and maybe use on demand. Who it's daily, the recommendation. And this is for SMM. We have to be, it's different for women. We have less data, but there's still data. And for women, it's probably daily that it will be recommended. Okay. So PK modeling suggests that about 7 tablets per week are needed for full protection from vaginal exposure. So, yeah. So what's coming? Injectable PrEP, rings, vaginal rings, world free of AIDS, stigmatization, we have to work against stigmatization. And if you think it's warm here and you want to visit Canada, so you can come to see us in Montreal during the winter. Thank you.
We have time for questions.
Are you still measuring CD4 T cells?
Yes. We try to decrease twice a year or less, but patients want, we use them to that, to that, you know. And it has more for the CD4 than the viral load, you know. But we really can decrease, that's for sure. It's not so helpful.
I'm Bharat Parekh from CDC, Atlanta. My question was about, you said about 2 hours before sex. So how, I mean, is the time effective completely, and how early before exposure the PrEP will be effective?
2 to 24 hours.
So 2 hours is good enough?
Yes.
Wow.
Yes, 2 to 24 hours, once a day for, the problem sometimes is that people, they have sex more than once, you know. So how long you add your pill after. And PrEP is interesting because I have some patients who are taking PrEP when they're going in vacation only. They know where they're going vacation, they are vulnerable. So I start 1 week before they go to vacation, during the vacation, 1 week after. And sometimes they stop after sometimes they're in couple in their real life.
Tom Quinn, NIH. Great talk. Two specific questions for you. In the U.S., where PrEP's getting increasingly used, like in San Francisco, Seattle, Baltimore, places around, our rates of STIs, as you pointed out, have astronomically increased. Now, the PrEP is going to individuals who are at high risk, and so you would expect that to some degree, but we're at the highest rates of syphilis right now. Gonorrhea, rectal gonorrhea is just... Same thing
for us.
Yeah, it is the same thing.
Yeah.
So we have now overemphasized in our clinics the STI part that you were indicating, trying to give them prevention and indications. Now, as you know, on the PrEP, or the on-demand PrEP, the French did a study and presented it where they actually gave prophylaxis for STIs, very controversial. They gave out doxycycline to the individuals going on PrEP, and everyone in the STI field got really nervous about that in terms of generating resistance. But anyway, that was one, just a comment, and if you had any any comments about that.
Some people believe that at the beginning, it's normal that we see that, but
Yeah.
as we see more and more our patients that we see asymptomatic, how many persons were asymptomatic and did not pass tests? Because we pass more tests to this population. The other thing is that we bring high-risk population who are not going to the clinic maybe.
Yeah, right.
So it's two sides, yeah.
Yeah, it's two sides to it. And the second question is really to the whole group, and that is, what is the frequency in which PrEP's being used in the Caribbean at this point? Not being used. Will it be used?
Not sure if anyone is here from the ministry who wants to take that. I don't believe it's incorporated into any national programs, treatment programs. I'm sure it will be used. You know, we tend to follow what's best practice, and I'm confident that we will do so. But I don't believe it's in any national programs. Is Brendan here? Brendan? Can you comment? You're probably the senior person. Yeah, no, I don't believe it's being used.
May I? Just to add, is Brent first?
No.
Okay.
Give your name, please, first.
My name is Alexander Pastoors. I'm from the Netherlands. I'm an HIV activist. And I would just wanted to comment also on the last speaker here on the microphone. And that is that, for me, as an HIV activist, is that we should never mix HIV prevention and STI prevention. They're two separate things. And we should not take away a method that we have to prevent HIV in order to prevent STIs. So that's my main comment. Thank you.
Well, it's an important issue, and you know, we have an increase of STI in our clinic because we're a STI clinic too since many years, since before PrEP. In the PrEP group, we still have maybe an increase that is more important. But I still prefer to treat gonorrhea and chlamydia than to have an HIV. And in our 1,600 HIV very high risk group, we have not one infection, not one HIV. And maybe they were not completely adherent all the time. It's quite surprising. We have a lot of anal gonorrhea, syphilis, lymphogranulome venereal.
Réjean, thanks for your talk. Our situation in the Caribbean is that we have a limited range of antiretrovirals. So it's like, and I don't mean this in any disparaging way, it's like window shopping when we see all the possibilities in 2017. Cost is prohibitive. And my question, though, is if you've started a patient on what you would consider in kind of an earlier regime, should you change to one of the newer regimes that's being promoted if the patient seems to be doing well and viral load continues to be suppressed?
Me, I'm doing a lot. I'm doing a lot because I try to give new drugs, the best drugs to my patient, but we don't have, I understand the resource issue, we don't have resource issue. But we have to be careful not to do, we have to be sure we have new mutations, because you remember the study with Merck, with raltegravir. If you don't have the background, if you don't have the resistance, and your patient is undetectable, maybe it's better to stay with the same regime for that moment.
Last question, please.
Okay, good morning. It's not a question. Thank you so much for your
Just
presentation.
identify yourself,
I'm
Derek.
Derek Springer, the director of PANCAP, the Pan-Caribbean Partnership Against HIV and AIDS. I wanted to respond to the question that was asked in relation to PrEP. At the second Latin American and Caribbean Forum in 2015, it was agreed that both Latin America and the Caribbean will move towards implementation of PrEP. So the Caribbean region as a whole has endorsed those targets. We recognize that it is part of combination prevention. Of course, What will determine how quickly countries move to PrEP is the cost. But we have already seen some countries moving in that direction, the Bahamas in particular. I just came from there a few weeks ago, and they've started to provide PrEP. Thank you.
We have to fight for better price.
Okay, thank you very much. Please show your appreciation.